Thank you. Just very briefly to wrap up on the prior authorization, because I think Senator Hassan spoke to it. There's so much frustration that goes on, not only on the patient side, but administratively. And it just seems that it is one of these situations where you, in order to meet the requirements, you've got to make sure that you are either putting your administrative assistant on speakerphone for 45 minutes. It's kind of this, it's not harassment, but maybe it's harassment. You just have to stay on. And it requires greater burden to provide the authorization that will effectively work to reduce the cost. But it seems to me that there's a line here when you're bringing on people to handle this. Will the standardization that has been suggested by you, Dr. Cutler, and others have echoed that will help? Is that enough? In other words, are we at a point that we've effectively started a secondary business here with just dealing with the insurance companies to get the sign-off and to get that approval? Is it just standardization that will address this, or is there more to this? Because this is something that everyone is complaining about. Dr. Cutler?
I think of standardization and of IT integration as being related. That is, you both want to standardize so you don't have 10,000 different requirements, and you also want to make it easy to transfer the information from the medical record as proof that the pre-authorization requirement has been met. So it can be seamless. The physician says, I would like to do X. The insurer's policies are clear because there's standardization about them. And then the IT systems can automatically provide verification that X was done. And then you don't need the people involved. So I think you get part of the way there just by standardizing, and then another part of the way through easy interchange.
And I understand all that, I recognize that, but in my mind, I still go back to Wrangell, where we have 8 beds, where your staff is limited, and yet the requirements are as significant as they are for a major hospital in Seattle. And so back to the issue of scale and why a rural strategy is going to be important, recognizing that we're just not equally situated. And even with the interoperability and the full integration of electronic medical records, I don't know if you have additional suggestions, Ms. Hultberg, that speak to these smaller facilities that still bear pretty extraordinary cost.
I do think, to echo Dr. Cutler, that technology is a piece of this. Technology can be a help, but right now it is sometimes a hindrance. Mm-hmm. So I think we have to figure out this technology piece, also recognizing that there may be other steps that we need to take to really enable us to continue to have a rural healthcare infrastructure that is meaningful. But as an example, Wrangell, this little tiny medical center on an island, is going to spend $65,000 this year on upgrading to meet stage 3 meaningful use. They're not going to see patient benefit for those dollars. They're having to purchase a software package with functionality they don't need. And earlier this year, Wrangell had less than 10 days cash on hand. So $65,000 in this committee room where you deal with billions of dollars may not seem like a lot, but for Wrangell Medical Center, it's really important. And for the residents of that community, it's really important. So one of the things we encourage is revisiting our current framework for electronic health records, removing some of those barriers, ensuring that we have interoperability, which was the promise of electronic medical records that has not been realized. And then I think we may see enough improvement that could be sufficient.
Very good. Thank you.